Hello everyone, today's topic is oxygenation, which is a foundation of EMS care that is easy to overlook or misuse. Oxygen saves lives, but too much of it can also cause harm. Our goal today is to understand when, how, and why we administer oxygen based on the patient's condition and current evidence. Who here was taught that you can never give too much oxygen? You might be surprised by how much that thinking has changed over the years. So let's start with what's really happening in the body when we oxygenate a patient. Oxygen is essential for cellular metabolism. Every cell in the body needs oxygen to function. Oxygen is what allows cells to create energy, specifically through a process called cellular respiration. Inside the mitochondria, which is the powerhouse of the cell, oxygen combines with glucose to make ATP, the body's energy currency. Without oxygen, cells can't make enough energy and they start switching to anaerobic metabolism, which creates lactic acid and leads to acidosis. Think about a cardiac arrest patient. Even if we restart their heart, if oxygen doesn't reach the tissues quickly enough, their cells start dying from energy starvation. That's why our immediate priorities are circulation and oxygenation. Oxygen is not just about breathing, it's about feeding every cell's energy factory. Hemoglobin is the vehicle that transports oxygen. It's a protein in the red blood cells with 4 binding sites for oxygen molecules. When blood passes through the lungs, oxygen binds to hemoglobin. When it reaches tissues with lower oxygen levels, hemoglobin releases that oxygen. Think of hemoglobin like an Uber for oxygen. It picks it up in the lungs and drops it off at the cells. Without hemoglobin, oxygen would dissolve very poorly in plasma, and your body couldn't transport nearly enough to meet its needs. That's why in cases like severe anemia or carbon monoxide poisoning, patients can look pink and have normal oxygen saturation on the monitor, but their hemoglobin isn't carrying enough oxygen effectively. The goal is adequate tissue perfusion, not just oxygen in the lungs. This is one of the biggest mindset shifts in modern EMS. Just because oxygen is entering the lungs doesn't mean it's reaching the tissues. Adequate oxygenation requires 3 things: ventilation, which is moving air in and out of the lungs, oxygen transport via hemoglobin in the blood, and perfusion, blood actually reaching the tissues. An example is if a trauma patient is bleeding heavily, their lungs might be full of oxygen, but if there's no blood volume or circulation, the tissues are still hypoxic. That's why we always pair airway management with perfusion management. The takeaway here is that our real goal as medics isn't just oxygen in the lungs. It's oxygen delivered to and used by the cells. SpO2 is only one part of the story. End-tidal CO2 is the gold standard for measuring these, but we'll cover that in the next slide. Now, oxygenation and ventilation are 2 different things. Oxygenation is about getting oxygen into the bloodstream. Ventilation is about moving air in and out of the lungs to exchange gases. Not just oxygen, but carbon dioxide too. In short, oxygen equals adding oxygen to the blood. Ventilation equals removing CO2 from the body. An example of this is a patient that can have great oxygenation, SpO2 99%, but still be hypoventilating, meaning CO2 is building up because they aren't breathing deeply or often enough. Just a quick end-tidal CO2 breakdown. I cannot talk about oxygenation and ventilation without at least bringing up end-tidal CO2. I'm not going to go in depth, but I'll have a end-tidal CO2 class just for that later on. So ventilation, first thing, is how well air moves in and out of the lungs. End-tidal CO2 directly measures the amount of carbon dioxide exhaled at the end of each breath. If ventilation slows, like in hypoventilation, CO2 builds up and end-tidal CO2 rises. If ventilation is too fast, like in hyperventilation, CO2 is blown off and end-tidal CO2 drops. An example is a patient breathing too fast after an anxiety attack. Their end-tidal CO2 is 25, which is low. And a patient that is in an opioid overdose, their end-tidal CO2 is 60, which is high. Next is metabolism, or how much CO2 the body produces. CO2 is created by cellular metabolism. Every cell that uses oxygen produces CO2 as waste. Increased metabolism, like in fever, seizures, or pain, cause higher end-tidal CO2 values. Decreased metabolism, like in hypothermia or cardiac arrest, cause lower end-tidal CO2 values. A seizing patient may have an end-tidal CO2 value of 50 to 55, and this is due to a high metabolic activity. Next is perfusion, or how well CO2 is carried to the lungs by blood flow. CO2 moves from tissues to blood to lungs and then exits the body as exhaled gas. If perfusion drops, like in shock or cardiac arrest, less CO2 reaches the lungs and end-tidal CO2 falls. An example is during CPR, an end-tidal CO2 value of less than 10 often means poor chest compressions or inadequate perfusion. A sudden rise in end-tidal CO2 during resuscitation can indicate the return of spontaneous circulation, or ROSC. End-tidal CO2 gives us a window into three systems at once. The lungs, this is ventilation, the cells, which is metabolism, and circulation, which is perfusion. If any one fails, end-tidal CO2 values change. That's why it's one of the most powerful vital signs we have. Going back to oxygenation, we have several tools to deliver oxygen, and choosing the right one depends on the patient's condition and need, not just what we always do or protocol habit. An example is a trauma patient that's SATi 96%. Do we put them on a non-rebreather? The answer is no. Oxygen should be titrated, not just an automatic thing. So for discussion, which you can pause the video or you can just wait to the end, but a discussion would be, what are the advantages of starting low and titrating up instead of blasting 15 liters through a non-rebreather? The American Heart Association and National EMS education standards emphasize targeted oxygen therapy, which is maintaining appropriate saturation instead of always going for 100%. Once your patient reaches the target SpO2, back down your flow rate. More oxygen doesn't mean better outcomes. AHA guidelines now recommend that patients with suspected acute coronary syndrome, ACS, or stroke not receive oxygen unless SpO2 is less than 94% on room air, if they're presenting with dyspnea, which is difficulty breathing, or if they have signs and symptoms of shock or heart failure. Now keep in mind though, that if a pulse oximeter is unreliable or not available, oxygen should be administered. So how do you oxygenate a chest pain patient or a stroke patient? Well, you can start with 2 liters a minute via nasal cannula. For patients who complain of dyspnea, experience signs and symptoms of shock or heart failure, or have an SpO2 less than 94% on room air, you will titrate oxygen to maintain an SpO2 of at least 94%. Now, how about those COPD patients? Why might we keep a COPD patient's saturation around 90% instead of 100%? When I was a paramedic student, I was taught that patients with chronic obstructive pulmonary disease, COPD, live with chronically high CO2 levels. Over time, their bodies would adapt to this and rely on oxygen levels, not CO2, to trigger their drive to breathe. We called this hypoxic drive. Since then, things have changed in this area. They say that the evidence of hypoxic drive was from a poorly done study, or maybe it was providers were just so afraid of hurting someone that they just withheld treatment. Regardless, we are now told to not withhold oxygen to COPD patients. If they need it, then give it, but do so with caution. The goal isn't perfect saturation, it's safe oxygenation without suppressing their breathing drive. Current AHA and EMS guidelines recommend keeping COPD patients in the 88 to 92% SpO2 range. That's enough to supply tissues with oxygen while minimizing the risk of CO2 retention and respiratory suppression. In a COPD patient, 90% saturation isn't under-oxygenating, it's right where we want them. However, if you feel like the titration treatment isn't effective, you have tools that can assist you in maintaining the airway and ventilating the patient appropriately. I want to emphasize that we do not withhold oxygen from a COPD patient because of fear of hypoxic drive. Our protocols specifically state that we do not withhold oxygen in these patients. We have ways to help a patient that might need some help breathing, such as CPAP or BVM. Just keep in mind that we want to be precise and know what and why we are doing what we are doing. Moving on to how oxygen can hurt the body. Too much oxygen for too long causes free radical damage, which is microscopic oxygen molecules that attack tissues. We see this in long-term ventilated patients, but also in the pre-hospital hyperoxia. A good example of this is in a post-cardiac arrest patient that is left on high-flow oxygen, later develops worsening lung compliance in the ICU. Over-oxygenation is always the contributing factor. So oxygen can both save and harm. Let's look at when it's most appropriate to give. As with any drug, oxygen has an indication, a dose, and side effects. We don't automatically apply oxygen just because a patient looks sick. Caution doesn't mean don't give it, it just means be careful and know what you're doing. For instance, with a stroke patient, the brain is one of the most oxygen demanding organs in the body, but it's very sensitive to changes in both oxygen and blood flow. During a stroke, some brain tissue is completely deprived of blood. That's the core infarct. Around it is what's called the ischemic penumbra, which is tissue that is barely hanging on and may still be saved if blood flow is restored quickly. Our oxygen goal in stroke care isn't to flood the brain with oxygen. It's to maintain just enough to keep the penumbra alive until reperfusion therapy is allowed to work. High levels of oxygen, especially prolonged SpO2 above normal, can increase the production of free radicals, which are unstable oxygen molecules that damage brain cells. In stroke patients, this oxidative stress can worsen the injury in the penumbra area. An example is, you might think that 100% oxygen is always safe, but studies show that over-oxygenating stroke patients can cause vasoconstriction, which is narrowing of cerebral blood vessels that reduces blood flow to already oxygen-starved tissue. So paradoxically, giving too much oxygen can decrease cerebral perfusion and increase brain damage. AHA and stroke care guidelines now recommend giving supplemental oxygen only if SpO2 falls below 94%. If a patient is maintaining 95 to 98% of room air, they don't need additional oxygen. You could be doing more harm than good. A quick rule is that in stroke, we treat hypoxia, not numbers. Oxygen is for need, not routine. An example scenario is you arrive on scene for a 68-year-old male with right-sided weakness and slurred speech. His SpO2 is 96% on room air. Do we apply oxygen? And the answer is no. He is adequately oxygenated. We keep him comfortable, maintain airway patency, and monitor saturation. Only if it drops below 94% do we titrate oxygen slowly, usually via nasal cannula at like 1 to 2 liters per minute. In stroke patients, our goal is adequate oxygenation, not hyperoxygenation. Maintain normal SpO2 around 94% and avoid vasoconstriction and free radical damage. More oxygen does not mean more survival. Remember, in stroke care, time is brain, but precision is protection. Too much oxygenation can turn a salvageable brain into an irreversibly damaged one. Now to our pediatrics. Pediatric patients are more vulnerable to hypoxia, but also more sensitive to hyperoxia. Use gentle titration and monitor closely. You can see from this desaturation curve how susceptible pediatric patients will compensate and then crash quickly. I have seen this a few times on scene and it's not fun to witness. Blow by O2 also helps with kiddos that might be scared but need some help. We really do want to avoid giving too much oxygen with these patients. Know what you are doing and why you are doing it. Oxygen therapy isn't a set it and forget it. We always want to be reassessing. We want to titrate down as the patient improves. If you need to set someone as a timekeeper, then do that, or you can set an alarm. You'd be amazed at how fast time flies when things are hectic on scene. For discussion, what does your documentation look like when titrating oxygen? Do you record when you decrease the flow rate? The answer should always be yes. Yes, you record when you reduce flow rate of oxygen, and you want to describe how the patient's condition changed. Use objective and subjective findings to report this. Giving accurate times is useful as well. You would do the same if the patient's condition got worse and you had to change treatment to match this new condition, such as going from a nasal cannula to a non-rebreather or to assisting the patient with a BVM. Make sure it's all documented. Remember, oxygenation is about precision. The best paramedics and EMTs use just enough oxygen to meet the body's needs. No more, no less. In closing, think about this question. What's one change you'll make in how you manage oxygen on your next call? Now I want you all to discuss this slide and see what kind of ideas everyone has. So have fun with it, and I'll see you on the next one.